Have you ever walked into a room and immediately forgotten why you're there? Or found yourself wide awake at 3 a.m. staring at the ceiling, wondering if you'll ever sleep through the night again? I'm Naturopathic Dr. Hussain, and this is Phase to Phase, the Hormone Health Show. Today we're talking all about perimenopause, a topic that we couldn't get anyone to pay attention to up until a few years ago, and now menopause is in the spotlight. More specifically, I find that menopause, like hormone therapy, is in the spotlight, but the rest of menopause care, like how sleep changes, mood changes, metabolic changes happen, we haven't really dove into that as much as we need to, and these are the things that people are really struggling with. One of the hard parts of this transition is that chronological aging, life, and hormone change are happening simultaneously, and there's no uniformity in how we all experience menopause. Someone else could be going through extreme volatility while someone else's experience is completely smooth. So that's what we're diving into in today's topic with my colleague, Naturopathic Dr. Laurie Alpert, who is a Menopause Society certified practitioner. She helps people navigate their healthcare and personal journey through perimenopause with more confidence, clarity, and choice so that they can feel more like themselves now and take full advantage of the decades to follow. We actually became fast friends on a clinician trip to Costa Rica, and I love that she is a gentle and strong force as a human and in the menopause space. Thank you for being here, Laurie.
Thank you, Anne. Thank you so much for having me.
I'm really excited to have this conversation because I don't know, do you agree that we've focused a lot on menopause therapy or like hormone therapy, but not as much on all the other things that people struggle with?
100%. That definitely seems to be the messaging in social media and elsewhere. It's like you're either for hormone therapy or against it, and there's very little space for the nuances and all of the other important conversations that need to be had at this time.
Okay, great. So I think we're going to have a great conversation. But first, I actually want to take a step back and start with some lingo because the lingo I think can be a little confusing, right? Because there's pre-menopause, there's perimenopause, there's menopause, and there's post-menopause. Could you be so kind and break those down for us?
Absolutely. And to your point, you will hear lots of people using these terms in various ways, but I will talk about the clinical definitions, the things that have been defined in the medical literature, and how we hope it's being used consistently in the medical literature, even if it's not being used that way in the media or elsewhere. So menopause is actually one day, and it's that 12-month anniversary of your final menstrual period. So once it's that retrospective look at, we had a period, it was our last period 12 months ago, and now on this 12-month anniversary, we get to celebrate, we've hit menopause. So postmenopause is after that, and, premenopause is before that. But this perimenopause is a range of time around that last period. And it's actually defined by menstrual cycle changes. So we're going to see menstrual cycle changes with variability of a minimum of 7 days. So what that means is if you're having regular cycles in your pre-menopause phase, ideally they're relatively regular, they might start to vary. So if they start around 28 days on average, and then once in a while you get a 34-day cycle, and then a 22-day cycle, and then a 40-day cycle, and we're starting to see that variability of, expand. So once you're having at least a week difference within there, that's what we call early perimenopause. And then it goes all the way up until that year after menopause. So it's really the time all around leading up to that final menstrual cycle.
Okay, thank you for explaining that because I don't think there's anything wrong with interchanging it, for patients, for example, right? But it does help create some clarity when we can be speaking the same language.
Absolutely. And it gets a little bit tricky, to be honest, because people may experience signs of fluctuating hormones before they start to see that variability in their cycle. And so whether or not we call it perimenopause is maybe not as important. It's important when we're starting to think about the research and where we have data and evidence for different interventions so we can communicate that clearly. But in terms of our own personal experience, it probably really doesn't matter if we have a 6-day variability or a 7-day variability. We're still feeling the things, right?
Yeah, exactly. Okay. And so you alluded to some of the changes that people might be experiencing, even if their cycles are sort of regular or not really changing. What are some of those signs? What are some of those changes that people are experiencing?
Yeah, so it's very different for everyone, as you said in the introduction, that people can have extremely varied experiences through this time. The most common sort of disruptions or changes I see earlier on will be changes to mood. And sometimes changes to sleep. So it will be that like worsening PMS. Maybe you used to have PMS, but you could handle it, or it would just be one day, and then it starts to become much more extreme. Those experiences of rage, a lot of people report, or depression, or even apathy. This kind of meh feeling. Um, and as well, we can start to see some subtle changes in sleep. And sometimes those changes only occur in that luteal phase, so that window right before your periods. It's not going to be every day, but there might be some cyclical patterns to it. And not everyone sort of tunes in that there's cyclical patterns to these changes. So it can take some observation and some good clinical digging or conversation with your care provider to figure that out. But I would say those, along with the third most common thing, would be some of these cognitive changes where, like you said in the intro again, where you walk into a room, you can't remember why you went into that room, or you don't remember where you put your car keys and they're actually in your hand. Not that that's ever happened to me. So some of those, word memory, I can't remember what the word was on the tip of my tongue. Those are the kinds of things that can show up a little bit earlier, and we don't always connect to hormone changes.
And at that time of life, there is a lot going on for people, whether that is, change in the family unit, change in work,
Mm-hmm.
change with identity, right?
Mm-hmm.
Like that's also the time where you're like, well, I'm like in this middle part of my life. What happens next, or what have I accomplished
Yeah.
so far? There's
Yeah.
a lot of questioning. Before we move on, can you share a little bit about how you came to focusing on this work and being an advocate and a clinician who's focused on perimenopause and menopause care?
Yeah, absolutely. It kind of found me the way these things tend to do. In my practice, when I had young children, I was focusing more on mental health and kids' mental health. And very quickly through that process, I realized that the kids' mental health was dependent on their caregivers' mental health, which seems obvious. But a lot of the caregivers I was engaging with were women between the ages of 35 and 65, right? Teachers, nurses, etc. And so all of these concerns were coming up repeatedly. And so it was through my own research, my own personal experience, these kinds of things, that just repeated exposure and finding ways to support my patients, that I learned more about perimenopause and all these subtle things that can happen, and the complexities of the overlapping life experiences, aging, responsibilities, and hormone shifts that happen through this kind of midlife transition. So that's how I ended up here. It was natural, especially for me too. It has to do with sleep and the sleep disruptions, which I know we'll talk about later.
Yeah, I really want to get into sleep because sleep is one of those things that we really need, obviously, but it has this cascade effect and it permeates into every aspect of life, right? So, what is happening with sleep, or what are the common things that people are experiencing? And could you even dive into a little bit of the physiology that might be affecting the sleep quality and time that people are getting?
So some of the things that are happening with sleep that are related specifically to perimenopause have to do with the hormone changes, but it's overlapping with changes that come with age as well. And, sometimes it's difficult to tease out, like you said, but we do see that as we get older, we spend more time in this lighter phase of sleep. So we're more easily aroused in the night. And then it can be more difficult to fall back asleep. So the classic pattern is, I'm so tired, I have no trouble falling asleep at night, but then I wake up in the night and I'm wide awake, or I can't fall back asleep for hours. Um, that's the classic pattern, but I do often still hear people have trouble falling asleep, or it's a little bit different. And that's because we have to consider all of the things that might be causing just your general chronic insomnia with the hormones and with aging. So the different ways that hormones are playing a role physiologically. Well, first of all, estrogen and progesterone have been shown to impact multiple sleep-wake centers on the brain. So independently of all the things that they can cause, like night sweats or hot flashes or palpitations, anxiety, those kinds of things, which we know can worsen sleep. Just by themselves, they have an impact on sleep. So there've been some really cool research looking at, measuring the body temperature and people's subjective experiences of waking up in the night because of these temperature dysregulation symptoms, and people waking up beyond that and getting improvement from some hormone replacement therapy, independent of the benefit to those night sweats. So it's definitely layered and complex. And then we have some impacts of, estrogen on its cortisol regulation in the night. And so sometimes those early mornings that we wake up at 5, we're ready for the day and we don't want to be awake at 5. Sometimes that's a little bit of what's going on. So there's lots of different things. I mean, I could go on and on. There's heavy bleeding in the early stages of perimenopause can cause iron deficiency, worsen symptoms of anxiety, even restless leg syndrome, which makes it difficult to fall asleep. There's increased risk of sleep apnea for various reasons, which also impacts our sleep. There's changes to the urinary tissues, so we're getting up in the night to pee more often. There's a lot of things going on all at once that just can wreak havoc on our rest and recovery.
And I think a lot of listeners will resonate with a lot of that, right? You mentioned the palpitations, mentioned the urinary frequency and getting to pee, and some people can fall back asleep easily. Some people may not be able to fall asleep easily. Temperature regulation, even in the household, I think becomes a point of contention. Right?
Absolutely.
Or my husband breathing beside me is really bothering me. It's another one that I hear in clinical practice a lot, that I never used to be like this, but him breathing or chewing is just like, it irks me. All of these things do impact us, not just sleep-wise, but then there's this cascade effect into our days. What are some of those impacts on someone's day, and when we compound that over time on their health and life?
Oh, great question. Well, definitely fatigue during the day. So then when we're tired, we're less likely to be inclined to do that exercise that we know feels good. We might make different food choices, more convenient choices that are, feeding kind of the brain centers, getting those dopamine hits. So maybe a little bit less nutritive in the moment. If we're tired, we don't have time to plan or strategize. Some of these changes can accumulate and lead to increases in blood pressure, which naturally occur with the changes of hormones anyway. And those dietary changes can impact our cholesterol. Like it kind of expands, and not to be all doomsday. I don't want it to sound terrible, right? Like there's so much hope in this time and so much beauty and opportunity and wisdom. But I really truly believe in the importance of sleep as a foundation. And there are things that we can do. And I think we just tolerate poor sleep for far too long, especially across this transition, because it can last a long time. And I don't want people to wait it out, because there just are ways to help. And the daytime impacts on our cognition, our memory, our sense of our ability to show up and perform. And that's when I like to challenge, though, too, because even our negative beliefs around our sleep can worsen things. So we kind of have to challenge this idea. Sometimes we're lying there thinking, oh my God, I'm not going to sleep. I'm going to be exhausted. I'm not going to be able to do anything. And really, it's like, actually, I can get through the day. I've been able to show up multiple times like this. It's okay. And sometimes remembering all of those opportunities we had and that we're going to be okay can help us calm down enough to facilitate falling back asleep. But it's not always the only thing. It's just a little piece of the puzzle I like to highlight.
Yeah, I agree. I don't think we talk enough about this. And I think it was one of our colleagues who said that she always thought she was a bad sleeper. And then she started shifting her mindset around it, and also realized that perhaps her sleep wasn't as bad as she thought it was. Right? Like the stories we tell ourselves really do make an impact. Can we also, because at this time of life, oftentimes, again, we might be relying on caffeine during the day to get through, and nothing wrong with caffeine. I have my coffee right here beside me. And then maybe in some circumstances, we might be using alcohol in the evening, whether that's to unwind, whether that's only on the weekends. But the impacts of alcohol start to be more exaggerated at this point, I feel, in this transition where people used to tolerate it quite well before, and now it's having a bigger impact on their sleep and mood.
Yeah.
What does that look like? What impacts can alcohol have? And maybe you can even talk about caffeine and alcohol in tandem. I'll leave that up to you. I'm very good at asking multi-layered questions.
Yeah, and I mean, you have such a great base of knowledge too, so I like to hear your inputs on this too. Yeah, so alcohol, absolutely, you nailed it. I have lots of people who just say they can't tolerate it the same anymore, and they kind of self-restrict because they make the connection that I'm either choosing to have this glass of wine or I'm choosing to sleep better in the night. So they know when they engage in alcoholic drinking that they're just not going to sleep as well. It has been shown in some people to worsen those vasomotor symptoms, so hot flashes or night sweats. Similarly with caffeine, maybe later in the day, we know that caffeine can impact our sleep, obviously. So there's clear connections there, and most people have made them for themselves. When, by the time I see it, I think it's a pretty straightforward one for a lot of us. And then these nighttime snacking, that comes with it and the impact on our sleep there and our next day's activities or that kind of thing, it just kind of can snowball a little bit.
Totally.
What do you see?
I see similar, right? Like I find that the biggest disruption from alcohol either comes through mood dysregulation, especially the next day, like a lot more anxiety.
Yeah.
And then the second thing, just like you said, is the vasomotor symptoms, like their hot flashes, night sweats are worse, which is disrupting their sleep.
Yeah.
And then sometimes it's what's happening is that they're drinking caffeine too late in the day, and then they're like, oh, I'm wired and I need to unwind. And then they're turning to alcohol a little bit, right? And I think the summers are also a time where my patients are very self-aware. I'm sure you have a lot of self-aware patients too. They're like, we're drinking a little too much right now, and my sleep is off, and my anxiety at night is through the roof, and
It's
I'm having
cottage
more hot
time.
flashes. Yeah, so that's the kind of thing I see. And then, like you said, appetite dysregulation is a very well-reported side effect of poor sleep, right? We move less, and in midlife, we are also just finding that people tend to move less in general. Right, like during the COVID lockdown days, that was amplified, and right. So there's many layers to this. Not to be again like all doom and gloom, but we want to set the stage of like what you might be experiencing, so that you can move forward from there, right? Because
Absolutely.
there are so many things that we can do. So take us through the basics first. So, what are some of the things that people can start to pay attention to, or how can we track better, perhaps, what some of the changes we're experiencing are?
I always recommend tracking your period. I think, historically people only did it when they were trying to conceive. But I think it's such an important data point for you to bring to your care provider, especially if you start to experience some of these mild symptoms before the timing changes. Because we can start to see, if you're tracking, let's say, your sleep disruptions or your mood alongside your period, we can see, is there a cyclical nature to this or not? Because all of these things can be impacted by things other than hormones, and we don't want to throw everything under the bus of perimenopause all the time. That's not always appropriate. But so it can help you and your clinician have a really good informed discussions, and it can help guide interventions as well. So definitely tracking some of these things alongside your period is very helpful. And then informing yourself and talking to your care provider. So asking for help, sooner rather than later. And the help might not be a medication right away. It might not be a supplement. It just might be a small tweak, a small behavior recommendation or change that can actually have really big impacts. So I encourage people just to bring it up sooner than later, put it on your care provider's radar so we can monitor as it, in case it gets worse, and intervene as soon as needed.
And you had mentioned sleep apnea before, and this is a time where sleep apnea can come up for people. What can that look like, and how do we go about identifying it?
Such a great question, because what we're learning is that it's really under-screened and undertreated in women. Historically, it was perceived to be more of a man's concern, but now we know that after menopause, the rates are equivalent in men and women. So menopause is a bit of a turning point of our risk susceptibility to sleep apnea. The challenge is that the existing screening tools are designed to capture the experience, how it presents in males, which it can present that way in females as well, but it can present differently sometimes too. And there can be subtle differences in that, we can look for snoring. Of course, snoring is a red flag, but not everybody snores. It can often present as just daytime fatigue or irritability or moodiness or even depression through the day, and not with overt snoring. So a lot of women don't realize that they might be susceptible to it, and then they could potentially be under oxygenating, for a third of their day, which has a huge impact on so many different things. So we really need to consider it, bring it up with your care provider. One of the things that's a red flag for me, if someone is talking to me about their sleep or their energy, is they say, I fall asleep fine, I sleep through the night, I get a good amount of sleep. Let's say they're 8 hours, they're 9 hours even, regularly. I don't feel like I'm waking up in the night, but I'm still exhausted during the day. And so there's lots of things that can cause that. We look at nutrient deficiencies, thyroid function, et cetera, screen for chronic disease. But that is one of the red flags for me, because to me, it could be, okay, they think they're sleeping well, but they're not, the quality of sleep is really compromised for some reason. So that's where we might try to get a sleep study.
Totally. And I am a big sleep study note writer to medical doctor because after perimenopause, the population I work with is PCOS, and it is 3 times as common in age-matched people to have obstructive sleep apnea in that if they fall in that population, right? I actually had a sleep study done for the first time this summer. It was not a great experience in the sense it's not a comfortable experience, but it's totally worth it because what I really found useful in a lot of these sort of situations is that they're obviously having the objective data, and then they ask you how you felt, right? Like you do the chart in the morning about how much sleep you thought you got, what it was like, how much times you woke up. And I was very glad that I was pretty close.
Good self-awareness.
Yeah, well, also like the competitive nature in me, right? Like I wanted to be right. But it was an interesting experience, right? Like, because it's oftentimes people say I don't get the best sleep, or I didn't get the best sleep when I did the sleep study, but it still gives us valuable information.
I also think people resist it because they think the only outcome is a CPAP, and they don't necessarily want a CPAP. And
good point.
There are other interventions in some cases, it's different depending on how severe the apnea might be. So I like to encourage people that, first of all, we don't want to miss, you not oxygenating throughout the night. That's really potentially big. So if you need a CPAP, there's a reason for it, and we will figure out ways to help you make that more comfortable. But it's not the only outcome of a sleep study that finds apnea. So there's dental appliances, there's positional changes you can make. There weight loss is one of the strategies depending on the situation. So there's different ways to address it. So I don't want that to be a barrier for people either.
Totally. I'm really happy you brought that up because also I have patients who have been recommended to you or have been prescribed CPAP machines. And for those who really need it, it can be life-changing.
It can be a game changer, 100%.
Right? Because sleep apnea also puts you at higher risk for something like hypertension or high blood pressure, which we don't want. And this is a time, perimenopause, when there's a lot of metabolic change happening anyway. So that's what I want to touch on next. What are some of the tests that would be important to consider at this time that we're really looking a little bit more closely at, especially keeping in mind the context from the past, because there's change at this time, right? So what are some of those tests that that we're typically screening for?
Yeah, I mean, I generally like, if possible, to do a basic screening for people. So we're looking at kidney function, liver function. There are metabolic shifts in your liver through midlife with increased risk of, fatty liver. And if we're drinking, that can be layered. It takes a while for that to show up on liver enzymes, but we just want to make sure that's okay. We're looking at our CBC and our ferritin to rule out iron deficiency. I like to measure CRP with that too, which is a marker of inflammation because that can help us interpret the iron markers better. And then obviously our lipids, like our cholesterol and our metabolic health. So our heart health, so there would be a lipid profile. We're lucky if we can also get ApoB and lipoprotein little a, which I don't know how in-depth we want to get into it here, but that can indicate some genetic risk of heart disease, which can, for me and my patients, it really helps inform conversations around how aggressively we want to treat elevations in cholesterol, for example. We're also going to want to look at, fasting glucose and hemoglobin A1C to assess for insulin resistance or, more advanced, prediabetes or diabetes if that's been missed because of some of these metabolic shifts that happen too. Thyroid, sometimes we want to make sure that some of the things that are associated with thyroid disease can parallel what we see in perimenopause. So weight gain, hair loss, skin changes, some of that can be associated with hypothyroidism or low functioning thyroid. So vitamin D deficiency too. That's one that the Menopause Society recommends. It's a test and treat. So we don't necessarily need to blanket supplement everyone, but we test. And if you are deficient, then it's helpful to resolve that deficiency. And I see that quite often with people who spend a lot of time outside and they're still supplementing vitamin D, and then we test and we screen and it's actually low. So that's a good one to screen for. Those are the main ones. I'm sometimes checking B12 because low energy can be tied with that deficiency. Am I missing anything, Anne? That's, I think,
No, I was going to say, I think you've got all of it. One of the questions that does come up is hormone testing. I don't want to get into it right now because I actually have a full episode on hormone testing, which comes out next. But I know we could have like an hour-long conversation just about that.
But good point to highlight that I actually didn't say any hormones in that sense, other than thyroid hormone or vitamin D is actually hormone, but no, like reproductive hormones. Yeah.
Because there's a time and place for things, and it's not a blanket recommendation for that one.
So listen to the other episode
exactly
for that answer.
Okay, so we've laid out a lot of things as to what can happen. Now, I obviously want to leave people with some tools and some considerations and some direction as to how to approach their medical team and their health team to set themselves up better. Can we first talk about some lifestyle modification that can help in general, but also as it pertains to sleep and maybe energy availability throughout the day?
Yes. Okay. So sleep hygiene. Some people have heard of this already and some people haven't. It's basically a set of behaviors that have been shown to promote regular, consistent quality sleep. So some of it, a lot of people are doing already. The things like, limiting caffeine, later in the day, having a cool, dark, quiet room, waking up daylight exposure is a good one. Potentially limiting screens in the evening or light exposure in the evening before bed. Like some of those really generic recommendations that you can find with any Google search. Those can actually make a difference. They tend to slip away through our day-to-day life, whether you're taking your kids to late sports or you just want a moment alone to scroll your phone and zoom out, or you work from home so you don't actually leave the house before you start your day and you get no sunlight. There's lots of things that can that erode in those behaviors over time. And then really just I find a big thing that comes up is feeding and fueling ourselves for the day and the demands that we're putting on our brains and our bodies that can really make such a big difference in our energy expenditure and our sense of energy throughout the day. So even when we don't sleep well, making sure that we are not necessarily skipping meals, that we are eating some breakfast, eating some lunch, the nuances of what you're eating, how much of your eating can really be discussed with your care provider. But I see a lot of people who just underfuel in general. And I think that's connected with some of those metabolic shifts and changes in weight and a history of, restricting nutrition leads to weight loss, but that doesn't actually still happen in menopause. Like there's changes there. But it's a pattern that's really easy to fall back on, especially when you're busy. So I spend a fair amount of time just coaching people through how to fuel themselves in a way that helps them feel better and have the energy to do the things that they say on their goal list they want to be able to do. Yeah, so it sounds kind of basic, and sometimes people laugh at themselves for the recommendation, and they know they should, but it's just all too common in the way our lives work these days in the modern lifestyle. And similarly for hydration, just drinking our water throughout the day. Those are like very generic, basic ways to start. And then it gets more complex from there, depending on the individual needs and goals.
Yeah, and And the foundations are always going to be relevant, right?
Always. Yeah.
Sometimes patients do come in and we're talking about fiber and we're talking about like
Yeah.
the basic things like eating breakfast. I had this conversation
Mhm.
actually on a previous episode on weight loss with Ashley, Dr. Ashley White,
Mhm.
that
Mhm.
oftentimes we don't front load our days when
Totally.
we really that would serve us quite well, and it doesn't have to be super heavily front loaded,
Yeah.
but we do the most in the first 2/3 of the day, and we oftentimes are under fueling in that time, and it's really hard to play catch up, and it's also very hard to have the regulation and the, quote unquote discipline then in the evening. It's not that we're lacking discipline, it's just that our biology is like, hey, you've ignored
Yes.
me all day, please feed me. Right? And
Yes.
those cues are just so loud at that point in time that nothing really will allay them unless like you sometimes even overeat, right? Like or and
Totally.
it's really hard, and then you feel like a failure because you're like, oh my gosh, I have no self-discipline, or oh my gosh,
Mhm.
I don't know why I do this to myself all the time.
Mhm.
And the conversations I think really are in our offices, as we've talked about previously, even they carry much weight and therapy because we're not only reassuring patient this is a very normal experience, you're not alone, but also
Mhm.
this is what everyone struggles with in some shape, way, or form. Even if it's not with
Mhm.
nutrition, it might be with exercise or with something else in life. And
Mhm.
I think that's the beauty of human connection too and conversation, right?
Yeah.
It's normalized a lot of my own thoughts about like, oh my gosh, why can't I get in bed at like 10 p.m.? Right. And some of that comes from previous wiring where I went to an afternoon
Yeah.
shift school, and
Mm.
that really primed me to be a night owl because I would come home and
Right.
would want to do homework, and I belong to a culture where everything literally happens 3 hours later than the time allocated for it. Right? So so there's all these layers competing.
Yeah.
And then
Yeah.
exercise is one of the other things that is
Mhm.
immensely helpful for metabolic health. But
Mhm.
tell us about exercise and its impact on
Mhm.
sleep, because it can really be helpful to help us fall asleep and have better quality, right?
Yeah, so the movement piece is key. So key that sometimes I forget to mention it because I feel like it's so obvious. But I also find that it's a bit tricky when people are so exhausted. I know when I was struggling with this, and my husband, who's like a lifelong exerciser, and I was too, but I was so exhausted, I was finding it hard to show up for even the most basic exercise. And he'd be like, "Well, you just need to exercise, and that'll give you more energy." And I was like, "Oh." That's not where I'm at. It's a bit of a catch-22. And for some people, they really are so depleted that starting with movement is not the right step. But I do talk about movement in like, maybe it's just stretching. Maybe it's just walking. Maybe it is strength training. Maybe it is, your HIIT training, whatever it is, like different levels where meeting you where you're at. And it's more about integrating or establishing that regular time allotted for movement when we're just getting started than it is about the specific type of movement. Then we get into more specifics. But exercise when it comes to sleep, I keep looking at all the research when it comes out, there's studies like what's the best exercise for sleep, et cetera, et cetera. And really, it's all good.
Yep.
It's all good. Ideally, not too close to bedtime, but move your body, and that will help you with sleep. So it's even better if it's outside and you get some daylight exposure, then you're getting those circadian rhythm cues to help you, especially if you're doing that earlier in the day. But I don't get too picky about the type of movement. It's something that you like feels good to you and that you want to go back to. So not so intense that you injure yourself or you dissuade yourself from doing it again because you're too tired or too sore. So when it comes to movement and exercise coaching, I'm actually very prescriptive and specific, and we'll talk details so that I can set someone up for success and for establishing this lifelong habit if it's not already one for them.
Totally. Same. I will literally
Yeah.
put it in their treatment plan. I'm
Yeah.
like, these are the 3 days. This is the time frame.
Yeah.
And this is a secondary time frame. So if you miss the
Yeah.
first time frame, this is the next time you're going to do it, but we're going to ditch the all or nothing thinking, because I think that's the trap that a lot of people fall in, right? Like the
Yeah.
perfectionistic tendency of either wanting to do it in a specific way or a specific exercise,
Yes.
or doing it 30 minutes or 0 minutes. And then
Yes.
we walk back that logic, right? I'm like,
Yeah.
even if you did 1 minute of exercise once a week and never did it again, that's still better for your health
I
than never
know.
doing
I know.
anything at all,
Yeah.
right? So
Well,
that's the mindset flexibility we want patients to have, that we all will have failure, we all will have
yeah.
backsliding. We just move past
Yeah.
it. And not to say it's
Yeah.
easy to move past it, but the more we do it, the easier it becomes, right?
Yeah, absolutely. And with my patients, we're looking at not only helping them feel better in the moment with what they're dealing with, but we're often having these conversations about setting them up for the rest of their lives, because perimenopause is this midlife transition where it's such a fantastic opportunity to intervene and make shifts to really like change the outcome and trajectory of where you're going for when you're 80. So the interventions I'm proposing, there might be some short term, but also I want to set people up for really long-term success. And that looks like behavior change, looks like habit change, and that doesn't happen overnight with like a 180. So like you
Totally.
said, it's small achievable goals, bite-sized steps and things that sets them up for success.
Okay. And I want to end our conversation with about the sleep, especially on what are some of the other layers. So let's say someone has sleep hygiene in place, their nutrition and exercise are in place, and they're still struggling. What kinds of
Yeah.
options exist? And I'm primarily thinking for in three buckets for sleep disrupted by hot flashes, sleep
Okay.
disrupted by urination, and then sleep disrupted for no known reason. I'll put it in quotes.
Okay.
If you can just go through, and again, this is not obviously medical advice, but what are some of the
Yeah.
considerations that we can, or things that we can use in those circumstances?
Okay, well, I'll answer one at a time and you can prompt me
Okay,
because I'll
I will.
forget. But so the first one for hot flashes or vasomotor symptoms, which can happen at night, like night sweats. I mean, hormone therapy is first line treatment for vasomotor symptoms of menopause. So definitely have that conversation with your care provider, see if it's appropriate for you, if it's indicated. If you can't take hormones, you're not interested in using hormones for those things, there are non-hormonal options, different like mood modulators, mood modulating medications, and even some of the insomnia medications and the sleep aids. There is a role for those in some cases. And I think they have a bad rap, but we have newer meds, like just in the last 10 years, that are less habit forming, much safer, can be used long term. And so I just want people to consider all the tools available to them. Um, you know, botanically, the Menopause Society would say there's not enough research for anything, but there are some things with some research. So if that's your cup of tea to use botanicals or herbs to help you through with the symptoms, you might get some minimal benefit from some of those, which I like to talk about a lot with my patients too. Um, Urinary symptoms. Okay, so urinary symptoms. Again, I would need to have a
Of
conversation to figure out
course.
what's going on with the patient, but a couple of options. So one is that sleep apnea conversation we had earlier. There is a link between this nighttime urination and untreated sleep apnea. So definitely rule that out. The most obvious intervention is like limit your liquid intake in the 3 hours before bedtime, which is sometimes hard for people, but also can make a big difference. We see reduction in sodium can also impact nighttime urination. So that has additional benefits on blood pressure, something to keep in mind. And then there's treating treating local vaginal tissues. So something like vaginal estrogen in some cases might be appropriate and can reduce some of that symptomology.
And I'll add
Mhm.
to that pelvic floor
Yes,
physiotherapy.
thank you.
If like, especially you also have urinary incontinence or some of those vaginal symptoms that Laurie was mentioning, because pelvic floor physiotherapy, again, like the pelvic floor is a bunch of muscles and they can really affect your bladder is tethered to them.
Yeah. And we
Um,
actually see the Menopause Society recommends that combination of vaginal estrogen and pelvic floor physiotherapy to have the best outcomes. So I'm often recommending those two together. So thank you for highlighting that.
And then the last bucket was just general, we don't know what's happening, or maybe there's some mood dysregulation that's contributing to
Yeah.
insomnia.
Okay. So again, within context of whatever else is going on, addressing that mood piece directly. So whether that's through, consideration of off-label use of hormone therapy, if, in the absence of vasomotor symptoms, that really depends on the conversation with your care provider and their prescribing comfort. We would want to look at the root of those mood changes. We can sometimes, again, use botanicals to support whether it's hormonal or non-hormonal. Mood modulating medications are often the first thing that doctors will recommend, and there definitely is a role and a place for those through this stage of life. Again, like similar to when you said one of your patients got a CPAP and it was like the life-changing treatment. And that's true for some of these SSRIs or mood modulating medications. It can be, people will often say, I wish I hadn't waited so long if they had felt resistance originally. So don't count that out. Exercise, nutrition, screening for nutrient deficiencies, like all those basics, foundations are going to have an impact on our mood, vitamin D. The list is so long, and it really depends on you and how you're feeling. So like everything, I always say perimenopause, like hormone therapy, it's so much more than hormone therapy prescription. The treatment or support through this time is much more than that. So talk to your care provider, like bring in the list. I know if you're working with a medical doctor in Ontario, they don't have a lot of time, but if you can contextualize it for them and go in with desired goals and then say, is this realistic that we can achieve this together today? That can be a great way to start the conversation, or set yourself up with a follow-up appointment if you need more care and attention, because everyone's experience is different. And so the strategy to support you is going to look different too.
I love that answer a lot because you essentially summarized everything that we could be using depending on the situation. It's going to be individualized, and we really encourage any listeners who are going through sleep issues or any perimenopausal change to reach out to their medical team. Again, like our family doctor situation, especially in Canada, is a little bit dire. So if you go in prepared, like Laurie's mentioning, and go in with your goals and asking them questions in a more succinct way, I think that sets you up for success planning ahead, and then rounding out your team with allied healthcare professionals. As we've already alluded to a couple of times, we have the luxury of time with our patients, which means that we can have these conversations in a bigger way and offer coaching. And I think that there's such power in that, and such validation and normalization and piecing things together, right? That transdiagnostic process that happens, because we can explore different things all at once and find solutions that will not just address one thing, but multiple things, and create a long-term strategy. And I know you're very good at doing that. Where can people find you? What's going on in your life? How can people connect with you and learn from you?
Yeah, thanks, Anne. So you can find me at my website. It's drlauriealpertnd.com. My handle on Instagram is drlauriealpertnd as well. I do have a sort of DIY transformative sleep course, so perimenopause sleep solutions, to help you really walk through some of the behavioral changes that can be helpful beyond sleep hygiene, and also do your own assessment and evaluation so you know what's going on, what's impacting your sleep, and which tools you might need to recover for this long-term plan of sleeping better throughout these years. I am also engaged in mentoring other integrative care practitioners who have a menopause practice. So I have a menopause practitioner circle to have conversations together to help us help each other through some of the gray zones of this kind of work that we do together. So there's lots of ways to work together, and I hope that we can find one.
Yeah, and I'll link
Thank
those in the
you.
show notes.
Thank
Before
you.
we end, so I'm asking this of all my guests on the podcast, because we're big on learning and unlearning here at Face to
Absolutely.
Face. What's one thing you've changed your mind on over time, or even more recently, if you'd like? You can take your pick as you've become older and wiser.
With all the grades to prove it.
Yeah.
I say this often to my patients. I really think I used to be much more dogmatically natural. So I've been doing this like 14 years now. So when I first graduated naturopathic college, I was drinking the Kool-Aid or the kombucha, if you will, and it was all natural. Your body heals itself and natural is best, et cetera, et cetera. But over the years, that has totally gone out the window. And I am much more about, let's use all the tools available to us. And collaborative care. Like I work a lot with other care providers to help my patients. So with their medical doctors, with their, pelvic floor physiotherapists, their therapists. I think that it takes more than one care provider through this time to help you feel your best and achieve your goals. So I think that collaboration is key. And So just understanding, the range of tools that we have, and that natural is definitely not always better. But I like people to have a menu, and it's your choice. So having those informed consent conversations around where the evidence is and where it isn't.
I love that.
Thank you.
Yeah. People are allowed to change their mind. Even in their care, people are allowed to change their mind.
Yeah. Yeah. I did it actually, a little quick story, but I love the collaborative care model, because in my clinic right now, we have a medical doctor, Dr. Ashley White, who you've interviewed, is on our team, and we co-care many of our patients. And, I had a visit with one, and I kind of thought and made one recommendation by the end of her visit, which I was referring her to Dr. White to explore. And then when I had a chance to talk about it with Dr. White, I was thinking about it, and I thought, I actually don't think I made the right call in that point. And so I sort of bounced it off her, and we changed the plan together. We said, yeah, actually, I think more appropriate is to try this other route. And so by the time the patient actually has that FaceTime with Dr. White, it's a little bit of a modulation, but it's because I reflected, and we were able to bring both our skills and experience together to support this patient. So it's really nice when we can change our minds.
Totally. And that's what we need more of, not just for menopause care, but any chronic health condition, right? That is multifaceted, multifactorial, and needs a multimodal approach, right? Fertility care falls in that category. PCOS care falls in that category. Endometriosis care falls in that category, right? There's so many conditions that fall under there where we need multiple inputs and multiple conversations and multiple facets to different conversations, and revisiting all of that over time. So I love that you not only shared that, but also brought that story up. And I'm very happy that you were here to have this conversation with us today and sharing all your wisdom on perimenopause and sleep and life.
Thank you so much for having me, and it's always a pleasure to talk to you. And it's also my favorite thing to share information about perimenopause, so people can start to, make the changes or take up the space that they actually deserve.
And if you're interested in hormone testing and whether it's appropriate or not for you, make sure to check out next episode all about hormone testing. And if you have a guest or topic suggestion for a future episode, shoot me a message through Instagram or at face2face.ca.